I'll just do a brief introduction of our guest speaker today, and we'll continue. It is a great pleasure and honor to have Dr. Amrou Sarraj here with us today as a guest Grand Round speaker. Dr. Sarraj is an endowed professor of neurology at Case Western University and George M. Humphrey Chair in the University Hospital of Neurological Institute. Dr. Sarraj graduated from Damascus School of Medicine, went on to complete his residency and fellowship in vascular neurology at UT Houston, where he held the position of tenured associate professor and director of the vascular neurology fellowship there. He has numerous first and last author publications in New England Journal of Medicine, JAMA, Lancet, Annals of Neurology, Stroke, and several other high-impact journals. He was a PI for SELECT-1 trial and more recently the landmark SELECT-2 trial looking at the safety and efficacy of large core thrombectomies, which he will be discussing with us today. Dr. Sarraj, thank you for being with us. You may continue.
Thank you so much, Johannes. Pleasure to be here with you all. As Dr. Rosenbaum said, I wish it was in person. But we'll have another opportunity, hopefully. We'll get to it. Let me just go back. So this is about the evolution of endovascular thrombectomy to include patients with large core, and this really moved. If you have been following the data in the field, from we don't treat these patients are not eligible. So there is a wild skepticism around it to where we are today, and how we will progress from within an hour from the start of presentation to the end, to this being the quote unquote standard of care with the concrete evidence behind it. These are my disclosures. The one that I usually say is I am not an interventionalist. So I am a vascular neurologist who does not do the procedure. Really, it's the science and the data that motivate me, and the patients, of course, rather than having more patients getting the procedure. As I mentioned, we'll go through the evolution of the evidence on thrombectomy overall, moving then to the large core, and where are we at currently with the large core evidence, and what are the next frontiers, so to speak. There's always questions remain on how things would be when you meet the patients, which imaging you use, what's an acceptable outcome when you discuss with the families, how systems of care will evolve, and where do we draw the line in the sand, because we always do with every treatment. So we'll start with this journey in time with stroke treatments. I mean, I tell my patients that stroke is a clot, sits in the blood vessel and prevent flow to the brain. The mainstay of treatment will remain reperfusion. Other treatments are always adjunctive, whether it's neuroprotection or others. So removing the clot, opening the blood vessel, restoring the flow would result in improvement plausibly and as approved by evidence. And this started with chemically with Altiplase IVTPA, the great work of the originals, Jim Brada and Pat Leiden and others, the 9DS1 and 2 trials proving TPA efficacy and safety. Then Tony Forlan, who I to an extent succeeded here, and Dilzebo did the PROACT trial, which is pro-urokinase, giving it to the clot directly in the MCA. And the PROACT one was a pilot trial, but that was against heparin. So when TPA came aboard, it changed things. PROACT 2 was actually a full power trial that showed benefit, but two issues happened. One of them is good, which is TPA. The other one is pro-urokinase did not become FDA approved. Then we had the MELT, which is the Japanese version of PROACT. which was stopped after several years without proven efficacy. Then we had a gap in evidence for thrombectomy efficacy and safety. Probably the residents here are not old enough to remember IMS3 synthesis and Mr. Rescue. In 2003, there were 3 trials that did not show benefit of endovascular thrombectomy, suffered from issues with the design, issues with patient selection, and the devices that were used at the time. So there was no benefit, but within 2 years, in 2015, we had avalanche of trials showing benefit of thrombectomy in the early window, from Mr. Clean to Escape to Revascat to Swift Prime, Extend I8, and there were 2 other European trials, Thrace and Pisti, that showed evidence of thrombectomy up to 6 hours in patients with small core. Then it was done in diffuse 3 after 3 years. That extended the window up to 24 hours, but that remains with small core, not with large core. So what is endovascular thrombectomy and who are we targeting here? You have a patient coming with severe neurological deficit due to a left MCA, M1 occlusion. You look at the CAT scan here, there are no ischemic changes, and we measure early ischemic changes on the Alberta stroke program, early ischemic changes on CT, the aspects. You see the occlusion here. You look at I tell the residents and the fellows that the golden rule in radiology, neuroradiology, is look for asymmetry, look to the right, look to the left, see if there is any difference, and there is none here, and that translates to the advanced imaging with perfusion. You see a large area of delayed flow. This is the rapid software, which takes the perfusion output and automatically automated to output. The output is the delay, the Tmax more than 6 seconds, and that is what we presume as salvageable tissue, or known for a long time as penumbra. And you here look, and you will see on other images if there is any dead tissue or infarcted tissue. I should say infarcted more than dead. Infarcted tissue, it will be here like a pink core, which is the area that has flow less than 30% as compared to a normal tissue. So this is a patient who harbors severe neurological deficit with no changes on the CAT scan or on the perfusion that is permanent. So this is by definition, reversible neurological deficit. You remove the clot, the patient should have higher chance of improvement. This patient was enrolled in the original SELECT trial, went to thrombectomy, had successful reperfusion, and you see the final infarct here on the DWI, small subcortical infarct, a little bit in the left frontal cortex, much smaller than the area at risk. This translates to clinical improvement. This is what the trials showed. This is what the original 7 trials in the early window, this is what DAWN and diffuse 3 patients were. Patients who have severe neurological deficit, no significant ischemic changes on the imaging, and those patients benefit significantly from thrombectomy. How do we measure? And because I will mention the modified Rankin scale repeatedly, we measure stroke outcome by functional outcome at 90 days. And that's the modified Rankin scale. And this is a cartoon showing you the scale is a 7-point scale from 0 to 6. 0 is normal, 6 is death, and 1 patient who had mild disability but low limitation of activity, independent, somebody who ends up with a little bit of numbness or very minor deficits. And if you have more deficits with some limitation of activity, but you're stable, still independent, it's a 2. Usually a good outcome in stroke, especially in large vessel occlusion, is a 0, 1, and 2. 3 is walking independently. You could walk with a cane. And 4, somebody in a wheelchair. 5, somebody who is required 24/7 nursing assistance. So usually the good outcomes 0, 1, and 2, but it depends on the population, and we'll discuss this further in large core. That 3 is a very good outcome in this population. So these are the trials that were early on that proved the efficacy and safety in small core. They put the data together in the Hermes meta-analysis. And you look again at the modified ranking. This is the more than almost 1,300 patients. You look at the thrombectomy versus the control population, 46% good outcome in thrombectomy, 27 in medical management. And when you do a procedure like this, you want to make sure it's safe. You're not harming patients. So also the death and very poor outcome was improved with thrombectomy. Probably was not statistically significant, but there was improvement. So you give your patients 2.5 likelihood of improvement as compared to medical management. And this translated to 1 in 4 patients being treated ending up being independent. And this is just to put this into context. You give aspirin to 2,000 patients to prevent 1 non-fatal MI and to 3,000 patients to prevent 1 non-fatal stroke. I'm not claiming that doing thrombectomy is like giving aspirin, but just to put things into context, this is one of the most powerful treatment effect in medicine. And when you say, well, what about the patients that only got TPA versus not got TPA? When they stratified, the treatment effect was maintained the same thrombectomy as compared to medical management. Again, the Hermes meta-analysis was for patients with good imaging profiles that I showed you, good aspects, good perfusion images, but that's not our population. It's just the evolution. And when you look at the forest plot of the Hermes meta-analysis, you see across the board benefit from thrombectomy in relation to age, imaging, altiplays, clot location, stroke severity, and time to treatment, and whether you had tandem occlusion or not. The most important population in this was the small core, the proximal occlusions, and the moderate to severe strokes. And our population is the large core. You see they did not really intend to enroll these patients. There were some patients basically in Mr. Clean and a little bit of in the other trials, and that crossed the no difference line. So there was no evidence, randomized evidence on that, and there were other population as well, but our focus is the large core. Then Dawn and Diffuse 3 came and extended to 24 hours. Again, similar to what I showed you, very small core infarction. This is an MCA, right MCA occlusion. See a very large area of tissue at risk, small area of core. You see the pink here. It's basically translated what we saw in the first 6 hours to the 24 hours, showing benefit of thrombectomy as compared to medical management. It's even stronger difference, absolute difference, and you may wonder why. Why? Because beyond 4.5 hours, you don't have thrombolysis. So patients in medical management did not have anything. And same with Diffuse 3, it was 6 to 16 hours, while Dawn 6 to 24 hours. Again, this is clinical imaging mismatch. This is imaging mismatch showing benefit of thrombectomy as compared to medical management without increasing harm. But that is, again, not our population. So which one is our population? I talked to you about slam dunk patients, no brainer. You have no permanent infarct on the CT or the perfusion. So you have reversible neurological deficit plausibly, and those were the patients that enrolled and improved. But this is a different population that we're talking about. You here start seeing changes on the CT. Look at the right MCA. You have very nice illustration of the head of the caudate and anterior arm and posterior arm of the internal capsule, the basal ganglia, the insula, gray-white matter differentiation, very nice. Versus you look at the left, you see a large area of hypodensity. So this is the low aspect, and you see this translate to much larger core on perfusion images as compared to the images that I showed you before. So those patients are not the no-brainer patients. So those patients, when you discuss as you evaluate any patients in the emergency room, there is risk and benefit ratio. And you and yourself or your interventionist will say, well, but there is a large infarct already. What am I going to do to them? and large infarct and opening the blood vessel will carry higher risk of reperfusion injury and bleeding, and that is quite plausible. But you come back and say, but if I don't do anything, I mean, this stroke will continue to evolve. We have a very large infarct and probably herniation and death. And at least if I do thrombectomy, I might avoid the herniation, I might avoid the hemicrania. And that's why you come to what you call clinical equipoise. So people would be willing to randomize these patients to thrombectomy versus medical management, and that's where clinical trials come to play. And we did this really methodologically. I started this back in 2015 with a non-randomized phase 2 trial, SELECT, smaller trial, United States-based trial, where we, in a non-randomized fashion, took patients who received thrombectomy or medical management with different imaging profiles with focus on the large core, and we published this in JAMA Neurology a few years ago in 2019. In SELECT, we had 445 patients enrolled, but not all of them were large core. We had 105 patients enrolled with a large core on CT or CTP aspects of 5 or less, or core volume of 50 cc or more, and the outcome, and again, non-randomized, so there are biases. Probably people treated patients who they thought would be benefiting. Of course, there is practice differences. You have the more aggressive people or the believers, and the less aggressive people. So again, when you don't have randomization, you take things with a grain of salt, but we saw benefit. I mean, you will see if the results were replicated actually in SELECT-2 or not. You have about 31% MRS of 0 to 2 in the thrombectomy arm as compared to 13% in medical management. And this was statistically significant with benefit both on dichotomized the MRS of 0 to 2 or on the shift. And the shift is very important. As you know, when you do the shift, you are looking at all the spectrum on the modified Rankin scale, moving from 4 to 3, from 3 to 2, from 6 to 5, from 5 to 4. So you capture the treatment effect more accurately. That was also positive. There was increase in symptomatic hemorrhage. The symptomatic hemorrhage in SELECT was reported by the site, so it's less sophisticated as compared to SELECT-2, where we had central adjudication and medical monitor. The mortality decreased, but it was not statistically significant. And the mechanism was the decrease in the final infarct volume and the infarct growth, which similar to what I showed you with the small core. So this made sense, and based on SELECT, we went and designed SELECT-2, a phase 3 randomized trial, looking at the efficacy and safety of thrombectomy in patients with a large core on CT or CTP or MRI, acknowledging that MRI is not the standard of care imaging-wise, and we had limited patients in SELECT-2 up to 24 hours. This was an international global study that was in the United States, Canada, European countries, Australia, and New Zealand, where patients came in and had initial CT plus CT perfusion or MR diffusion perfusion, dependent on the site practice, with covariant adaptive randomization. So you balance things. You don't want the sicker people, the older people, the later treated people in one arm, and the healthier or less severe people in the other arm. So we had pretty balanced randomization. We planned on enrolling 560 patients with adaptive enrichment design. We had pre-planned looks to see if certain patients would not benefit and should be excluded, patients with very large cores, very low aspects, but that did not happen. We have 2 pre-specified interim analysis, 200 and 380. We passed the first one. Then there was a Japanese trial, Rescue Japan Limits, that showed benefit at the International Stroke Conference 2 years ago. And the DSMB asked us to look additionally at 300 patients, and that's where they stopped us permanently. The primary outcome, as I mentioned, was the shift on the MRS. secondary outcome were MRS 0 to 2 and 0 to 3, and we'll talk a little bit more about 0 to 3. And you want to look at the safety with symptomatic hemorrhage and neurological worsening, mortality, and procedural complications. So this were secondary outcome, much bigger map as compared to what I showed you in SELECT. We had about 2/3 of the sites in the United States and Canada, and if you have quite a bit, about 10 sites in Europe, 5 of them actually in Barcelona, and we had 4 sites in down and under in Australia and New Zealand, and this is just an important aspect. If you look at the enrollment, we started in October of 2019, and if you look here, this is the heart. This is the heart of COVID, and I remember vividly getting letters from IRBs and sites asking us to terminate the trial, and we didn't. We adjusted. We came up with resolutions and solutions to things, as in remote consenting. Some countries, as in Australia, you can have a waiver of consent. We have a modified waiver of consent because they perceive this as a dangerous population. But we fought through it, and a lot of credit to all of the sites and investigators and coordinators to do that. And actually, we peaked during this time up to 3 years later when the DSMB asked us to stop permanently. And this is the enrollment chart, and you have US and non-US sites, and we ended up about 25% of the enrollment being non-US sites. And I'm really proud of this collaboration, because it's rare that 2/3 of the sites enroll 10 patients or more. Usually in clinical trials, and go look at prior trials that I referenced before, it's 2 sites that carry the trial and enroll 80% of the patients. That was not the case. That was enrollment from a lot of people. So we randomized 352 patients. 178 went to thrombectomy, 174 went to medical management, 2 crossovers, which is not too bad. And we only lost follow-up for 4 patients. Really, really, really good efforts by the sites. The intention to treat is the main analysis. This is your table 1. This is your large vessel occlusion population, but a little bit sicker. If you look at Down and diffuse 3 and Hermes, they revolve around 5, 15, 16 of a NIH stroke scale. This is 19. But most importantly, if you look at the core size, Down, diffuse 3, and Hermes in no order, the median was 8, 9, and 10. And we're talking here about 80 cc's or so. This is a large core population, and a good illustration of it. Also, time-wise, we had good breakdown between early and late window, and this was one of the pre-specifications, because you have theories. I mean, one of my partners, Bruce Campbell, always thought that there is probably less benefit in the late window, and that's why we looked at 0 to 12 versus 12 to 24, and this was one of the population that could have been excluded if there is no benefit. So let's see how we fared. So this is the primary outcome, and this is the modified Rankin scale in medical management versus thrombectomy. And you are not going to see any more 40% or 50% good outcome rate. So you see that in 80% in medical management, they ended up with 6, 5, and 4, limited patients in 3, 2, and 1, and none and 0. While in thrombectomy, you do have a shift towards better outcomes. Yes, of course, you have large proportion of patients who had very poor outcome, but you have a few patients who had 0, more patients with 1, 2, and 3, and a shift towards improvement. And this translated to statistical significance, and 1.5 the likelihood of improving at least 1 point on the modified Rankin scale in large core patients treated with thrombectomy as compared to medical management, and a number needed to treat of 5, which is excellent. Again, this is a different population that you saw before, but you're not comparing thrombectomy to thrombectomy, you're comparing thrombectomy to medical management. So yes, thrombectomy patient did worse than thrombectomy in small core, but medical management comparison was even worse. How about the secondary outcome? This is the modified Rankin 0 to 2. Remember, in SELECT, in the initial trial, it was 31% versus 13%, and I talked about possible biases. So this turned out to be 20 versus 7%. So absolute difference is close, and a number needed to treat of 7, and an MRS of 0 to 3, which I think the most appropriate outcome was doubled in thrombectomy, 38% versus 19%, and a number needed to treat of 5. Now, symptomatic hemorrhage rate, and people say surprisingly, I'm not sure if it's surprising, it was low in both population, and there is a paper from Michael Chen, should be coming within the next month on this specific point. This rate was low both in thrombectomy and medical management. Remember, we looked at the SITSMOS, which is at least 4 points worsening with a pH of 2. These are patients who come in with very severe deficits. Their NIH is very high to start with. Their non-symptomatic hemorrhage or all hemorrhage rate was 78% in thrombectomy and 52% in medical management. So it is high, but in order for you to worsen significantly by 4 points, it takes a lot in a patient who is sick to start with cerebral edema and others. So this was low, and it was similar in other trials. Mortality was lower with thrombectomy, but was not statistically significant. A persistent thing that we saw that early neurological worsening was higher with thrombectomy as compared to medical management. And there is a paper also coming from the Royal Melbourne group on the early cerebral edema due to reperfusion that very, very nicely explain that, but this did not detract from the overall benefit. The as treated and per protocol population showed similar shift in treatment effect and benefit. So this was consistent. This is the forest plot, and this is the no difference line. And if you look universally, it favored thrombectomy as compared to medical management. And when it comes to age, stroke severity, time, we talked about time and 0 to 12 versus 12 to 24. The treatment was persistent. The different core volumes, the different aspects, and the mismatch, no mismatch, which is a major deal and different population, because we excluded patients with good aspects that were a product of large core perfusion. We excluded patients with good perfusion that were low aspects. We went with the most strict population, large core, both on CT and CTP. And this was beneficial in the subpopulation A and B. Did not differ by hemisphere. There was a geographic difference, but as I mentioned, the non-US sites only enrolled 25% of the patients, so this was not powered to detect it. There was no heterogeneity. New England Journal of Medicine does not allow you to give p-values, but you will see them in another paper next month. Those were not statistically significant, and those are the important population based on the age and the stroke severity and the clot location and time that I detailed before, and they all favored thrombectomy. This is a large core trial, and core is important, and whether you believe in perfusion or not, it's important to look at the volumes. We had 2/3 of the patients of 70 cc or more, 1/3 of the patients of 100 cc or more, and 13% of the patients with more than 150 cc, and that is a very, very good illustration. Overall, thrombectomy was beneficial. And again, I repeat, there is beneficial, meaning that the treatment resulted in better outcome in thrombectomy versus medical management. That doesn't mean that a patient with 140 cc's did as well as a patient with a 70 cc's. As the core volume increased, and there will be a paper on this next month at the ISC, the likelihood of achieving MRS of 0 to 2, 0 to 3 decreased, but it remains that they performed or resulted in better outcome as compared to medical management. So this is the conclusion that I went over before, that in patients with low aspect or large core perfusion on MRI, there was a shift towards better outcome on the ordinal outcome and improvement on the dichotomized 0 to 2 and 0 to 3. And of course, this is the effort of a lot of the investigators and coordinators everywhere. The appendix of all of the select 2 investigators is at the end of the New England Journal of Medicine publication. I cannot put the pictures of more than 500 people. Those are the site PIs, the steering committee, the DSMB, and the statistical team, and I'm always grateful for their support through the trial, and the paper is published in New England if you want to read more details. So we did not stop here. There were other trials that were published either before. I referenced the Japanese rescue Japan limit. There was a simultaneous publication at the same time from China with the Angel Aspects trial. So at the time, there were 3 trials. We met at the stroke conference, Professor Yoshimura and Dr. Hugh and Professor Miao, and we formed a collaboration called Magna. Fits very well with large core, and I presented this at the European Stroke Conference last year. 1,000 and plus patients from the 3 trials of large core, and similar characteristics to select 2. Rescue Japan limit had a little bit of more sicker patients, Angel Aspect milder patients, so you end up with somewhere in the middle large core population illustration. But it's important to look at the evidence in totality. And with more than 1,000 patients, you see a shift towards improvement with thrombectomy as compared to medical management, and improvement in the very poor outcome that was statistically significant in all of the shift, MRS of 0 to 2 and 0 to 3. Mortality, and this is the fallacy of having more than 1,000 patients, so I need you to be careful. This approach statistical significance, but you have to look at the numbers, 28% versus 27%. This is by far not statistically significant. The symptomatic hemorrhage was not higher. There was about 10% rate of complications, but this did not detract from the treatment effect. And the beauty of having more than 1,000 patients, this is the opportunity to look at all of the subgroups that you don't have powered in a single trial, rather in the group, and you start seeing better confidence intervals and better stratification. Instead of saying more than 100, you say only 100 to 150. This gives you more precision when you meet with your patients in the emergency room on how to prognosticate, so to speak, on how they will do. And across the board, there was benefit. You see persistently, whether in Select 2 and the other trials, around 150, you start seeing maybe there is no benefit there. We don't know. That's what I think. It doesn't matter what I think. What we need to do is to there are 3 other trials that I will mention that we will group the data with, and hopefully within 2024 you will see a unified publication from all the trials. But again, universally, there was a benefit of thrombectomy as compared to medical management. This is stratification from the Magna based on the aspect. This is aspects of 3. This is aspects of 4. This is aspects of 5. And you see that in all of them, there was a shift towards benefit with thrombectomy as compared to medical management. Very, very logical treatment effect difference. The aspects of 5 has larger effect as compared to the 4 and 3, which makes the data very plausible. The aspects of 0 to 2, and here it's from me, and this is from individual patient meta-analysis. This is not accurate, because those trials excluded the patients largely. You only have 90 patients. The Tesla enrolled patients with an aspects of 2, LASTA enrolled patients with the aspects of 0 to 2. When we group everybody, when we have large number of patients, that is when we see if that's beneficial or not. And that is where you will get your guidelines and how those patients will fare. Stratification by the core volume, the trials, because they have aspects, they have patients of core less than 70, and you see, of course, benefit there. We knew that from before, but also when you look between 70 and 100, 100 and 150, there is benefit, there is statistical significance. And when you get to over 150, that is where it becomes questionable. But is it a question of the number of the patient? Is it a question of really the lack of treatment effect? That we will see when we have the rest of the trials in the meta-analysis to look at. So I referenced 3 other trials. Tesla, which is a United States-based trials, was presented at the European Stroke Conference. I'll show you the results in a second. Tension is a German-European trial. And as you see, different flavors and populations. Some enrolled based on the aspects, some enrolled based on the aspects and the DWI, some enrolled largely based on the MRI, the LASTE French European trial, different time windows, 0 to 24 versus 0 to 12 versus 0 to 7. And that's very good for the meta-analysis because you have different populations and heterogeneous population that you can look at, different groups and different questions in terms of times and severity and aspects and MRI. So this is tension that is published in Lancet as of October of last year, and it showed persistent results. Those trials were either stopped or completed. Tesla was completed. Tension and LASTE were stopped because of the results of SELECT-2 and the other positive trial. It becomes unethical to randomize patients. So there was a shift towards better outcome with thrombectomy and tension, improvement in 0 to 2 and 0 to 3, even mortality. There was statistical significance. That's why we didn't find that in SELECT-2. Angel Aspects and Rescue Japan didn't find that. It's best to wait for the meta-analysis to have precise treatment effect and whether there is benefit in mortality or not. Tesla has a Bayesian design and pre-specified probability of superiority that they set as 0.975. And as you see, they approached that. They really did, but they missed significance. To me, the most important thing is to look at the treatment effect or the treatment direction. The treatment effect is in the same direction. You're not having one trial, there is harm, one trial, there is benefit, one trial, there is no significance. They're all persistent on either having statistical significance or approaching statistical significance. That means that the treatment is effective. This is credit to Tudor Joven and Twitter, or formerly known as Twitter X. He showed the slides of LASTE that is not published yet. Tesla is not published yet, and there is a shift towards better outcome. LASTE 0 to 7 hours. However, they allowed aspects as low as 0, but that's based on the MRI. So it's a different animal. We'll wait for the publication and the pooled data, but also showed benefit of thrombectomy as compared to medical man. So the evidence in totality tells you that EVT is safe and efficacious in patients with large core through multiple randomized trials, 6 of them. 5 if you want to be strict and say Tesla was not positive, with consistent treatment effect across the trials despite different imaging modalities, different population, different locations, Asians versus Europeans versus United States versus global trial like SELECT-2. And this definitely support the expansion of patient eligibility and offer the opportunity to further improve patients and their outcomes and get them back to the society and their dear ones, something that we did not have before these trials. So do we stop here, or there are questions remain? There are always questions remain, and I will examine a few of them and point to a few things. How large is too large? Where do you stop? When you put your protocol, people want to know. The human being, the nature of the human being, we need to stop giving TPA at 3 hours or 4.5 hours. Is thrombectomy should stop at aspects? Should thrombectomy stop at aspects of 6? Does it go to 5? Is it 4? Is it 3? Is it 2? And that's what I showed you in some of the slides. In SELECT-2, we did not find a ceiling effect, but no question that as the core volume increases, as the aspect decreases, as I showed you in the Magna, the MRS of 0 to 2 rates decrease, but it decreased further in medical management. That's why you maintain the treatment effect while the likelihood of achieving a certain rate decreases. Same for the MRS of 0 to 3, but it remains statistically different. And this is where prognostication plays a role. Do you want to treat everybody? I don't think this is wrong. I think this is what a lot of people want to do. But do you want to talk to the family? And I think a lot of us do, and do a prognostication. And that when you become here and say, well, more than 150, only 13%. And some people look at SELECT-2 data in the N and say only 4 patients achieved MRS of 3 when they had a core volume of 150 or more. I think this is a good number. I think having 10% or 13% is pretty good likelihood. It's not high. It's not 40%, 50%, but I don't think it's a number to brush off and ignore. But I think that's where more of the fine art of medicine and individualizing the evidence that you have come to play. And that's, I think, what perfusion can offer you. This is from our colleagues in Japan. They found that there is benefit in aspects of 4 and 5, not in aspects of 3. I think this is due to the small sample size. This was an only 203 patient trial. While we found in the Magna there is benefit of aspects of 3, I don't think aspects of 3 is a question. I think the question will come as 2 and 1 and 0. We'll see what last results show, and we'll see what the pooled meta-analysis will show. The other question is, do you need CT perfusion? I'm sure a lot of people ask that. I will show you, the same aspects, 2 patients with the same aspects, but a wildly different core size, 100 cc difference between the 2. I showed you earlier that the outcomes decrease as the rate of 0 to 2 and 0 to 3 decrease as the volume increase. So probably that's where perfusion comes to play. There are people who say treat today and prognosticate tomorrow. I don't have a problem with that. I just show you the evidence, and everybody tailor it to their practice and to their patients. But I think there might be a role for perfusion there. I mentioned that there will be a SELECT-2 imaging paper presented at the IC and simultaneously published, so you will have more details on that there. And then what's an acceptable outcome? I mean, this is, set your expectations. I mean, I had some people asking me, well, we don't have improvement at 24 hours. So how do we keep doing that? I do not know how a patient with 120 cc's who get thrombectomy today will be running through the hallways tomorrow. That is not your small core population. So be patient. Give your patient an opportunity to improve. That is why we look at the 90 days outcomes. And we actually in SELECT-2, we looked beyond 90 days or 3 months. We have the 1-year outcome paper coming out at the ISC and presented at the last day of the plenary session with a simultaneous publication that we will learn a lot from. Do we need to expand rehab beyond 3 months? It's plausible that this population have larger infarcts, so they need more time to recover. I think the MRS of, so we'll see what that shows. I hope that you all will be there and see it. We talked about not comparing thrombectomy to thrombectomy and small core to large core, but we will. So what is an acceptable outcome? I think here probably the MRS of 0 to 3 or the MRS of 3 specifically is the most acceptable outcome. Just remember, this is a patient with an M1 or IC occlusion coming in with 100 cc of infarct. I think walking with a cane and being independent in that term is a very reasonable outcome. But we'll see what the society say. From societal standpoint, and there was an excellent paper from the SNES leadership after the 3 initial trials that said, well, more than half of the patients being cut from MRS of 5 to 4. And that is significant because you're moving a patient from nursing home to potentially going home with the family. I think that's from societal standpoint is quite important. And how systems of care will evolve and sit with that. I mean, the population in SELECT is about 20%. If you remember, I told you that SELECT was 445 patients. and the large score was around 105 patients. So it's about 20-25%. You might have increased because some of these patients were not transferred to receive thrombectomy prior to that. But I don't think that people will quitting their jobs because a large core will flood the gates. It's the same thing that happened when the initial evidence for thrombectomy came all together back in 2015. I think we adapted very well. Definitely, we need some of the residents here to be inspired and go to stroke and probably interventional to help more patients and have more access to patients towards thrombectomy, because at the end of the day, it's about the patients, about improving the patients. It's about getting them back to their dear ones and to the society. And again, can't speak enough about the support that I got from my co-investigators and the teams. I mean, this was COVID, but out of the 31 sites, I think I visited about 20 restrictions or no restrictions. I didn't get all the way down to Australia and New Zealand, but I have gone to the European sites, to the sites in the United States, because without them, this does not happen. And with that, I close. I'll be happy to answer any question. Thanks, Johannes, and everybody for having me.
Thank you, Dr. Sarraj, for this very comprehensive discussion. If anybody has a question, you can type it in the chat or you can unmute yourself.
Yes, good morning, Dr. Sarraj. This is Nick Palmitsakis. I'm a stroke neurologist here at Downstate. Thank you very much for this, very detailed and, comprehensive presentation, including everything from the history. Also, that all of the stroke practitioners are familiar with the struggles, obviously, over the years. My question is about the CTP, and I think you touched upon this because it is something that we always, require, at least our interventionalists. With this data regarding the large core and the issue of, relying mainly on aspects, maybe is there a time to abandon really the CTP and just go with a plain CT and CTA? You mentioned that obviously the very large cores might eventually not benefit, but the alternative is also very poor. So what would be the downside to let go of the CTP when in the end actually we don't always know if this penumbra really reflects always the salvageable tissue? What is your opinion? Maybe a trial would be something to be done focused on, just CT aspects and CTA. What are your thoughts about this?
Yeah, well, that's an excellent question. And I think everybody who's familiar with the stroke field, there are CAMs who are CT perfusion, and there are CAMs who are anti-CT perfusion. For whatever that works. That's why we did select two in this fashion. We wanted to look at CT versus CTP, and I think that the paper that I referenced that will be simultaneously published with the ISC will give you a lot of flavor into that. I think to summarize, first, I don't think there is a need for a trial. There are trials that were done based on CT only and showed benefit of thrombectomy, tension, and some of the MRI trials. I think for patient selection, I think if you come and say, I will treat all of the patients with aspects of 2 or more, I think CT is sufficient. I think when it comes to prognostication and more precision, and are you going to exclude patients on the CTP? I think the data argues against that. Are you going to look into the potential outcome and refine your treatment decision? I think that's where the CTP role comes to play. And you may say, well, what is the downside? I mean, you know, sometimes people would come and say, the 80 years old who has 150 cc's, probably, just like, you know, an analogy, a stage 4 advanced cancer, why would you treat in an elderly patient? I think that's where CTP role might comes to. I mean, we'll see what the guidelines say. My stance here is that for selection, CT might be sufficient, but I want to see how the aspects of 0, 1, and 2 comes in the publication of the trials that are not published, specifically Tesla and last day, because if you have question mark around the aspects of 2s, then how do you refine that, especially with the disagreement on the aspect 3? Do I think that you should exclude patients based on the CTB? The data doesn't show you that. Do I think that there is a role for refining the decision? Maybe, but I think everybody should tailor it to their practice. I think the data tells you it should not be mandatory, but should it be completely excluded? Let's see the rest of the results and some of the publications that will come in the guidelines.
Yeah, thank you. But the practical reality is that we use CTP, at least that's what I have experienced, to really exclude patients. And you mentioned obviously the results there with MRS scores.
Right.
And we know from the hemicraniectomy trials that, obviously there even an MRS of 4 was considered kind of a relatively good outcome. I think in order to make these decisions, one needs always to, as you also mentioned, to have the patients or families' input regarding this. And then, if they want to take the risk, let's do it. I think that's my personal take on this.
I think we said the same thing. I mean, if your guideline for your practice at your hospital say will not treat patients with a core volume of 150 cc's, then you might be questioned, why are you saying that when there are trials that did based on the aspect? If you say that patients with, that's at least what we say at our center, patients with less likelihood of benefit in a certain volume or certain profiles, I think that's the most reasonable based on the current data.
Okay, thank you very much.
Happy to help, no problem.
Good morning. Thank you so much for the great presentation, Dr. Sarraj. This is Tony Wang. I'm one of the neurointerventionists here at Maimonides, and we cover the downstairs as well. You mentioned that one of the goals to potential benefits to reduce the morbidity, but also the potential rate of hemicraniectomy. Did you have the data to show us, or any of the other trials that they look at the hemicraniectomy rate of these 2 different treatment arms, whether there's any changes for those procedures required?
Yeah, I'll sound like a broken record. The International Stroke Conference, Scott Kastner will present the hemicranie data from SELECT2, and it's very, very, very neat paper, because it's also taken into effect the treatment decision and when palliative care was decided and all of that. I mean, there are practices, and that's why the rates of hemicranie is a little bit affected by that. There are some people who are more aggressive than others. There are people who will say, well, patients who got thrombectomy more likely to get hemicranie. Let's see what we find. I think the lesson that I learned the most, and I think that's important for the 1-year outcome paper, is there is tendency that on day 1, if the patient is not improving and they have a very large infarct, that let's go and call palliative care. I think that is I mean, there are certain patients where you have a huge infarct and herniation and a large bleed or something like that, that this could be reasonable, especially in certain age group. But I think, delaying those decisions and allowing chance for recovery, and maybe doing hemicranie to give the patient opportunity for improvement, because the hemicranie trials did show that. I think this is the way to go. But yeah, that paper will show you the hemicrania rate and if there is a difference or not, and also it digs into the decision making, and also if a hemicrania results in improvement overall.
Great, thank you. So in your practice, knowing all the data we know so far, your selection criteria for thrombectomy for the anterior circulation large core or no core, of course, is what aspect score is 2, 3,
3.
or 150 or 100. But it looks like the smaller core, the better 3 to 4, 3 to 5 has the highest beneficial effect that constitutes most of your modified ranking shift from the left.
Right.
We have 50% of the population around 4 and 5 and 6 cohort grouped together, even though there's internal shift. Less so for the 6, but more for the 5 to 4.
Right.
So what is your cutoff?
Our criteria is aspects of 3 or more. The interventionalist, and you are an interventionalist, they have their own input as well, because of the low rates of MRS of 0 to 3, specifically 3 for more than 150. We did not say we will not treat more than 150. We just stratified them as patients with lower likelihood of achieving certain outcome. So that's where discussions come to play. But we treat patients with aspects of 3 or more. We don't have data on aspects of 0 to 2 yet published. I mean, there is a difference between a presentation or something posted on Twitter versus a peer-review publication. So we'll wait for the peer-review publication. I think that's where the guidelines really will help everybody. And I think that there will be something coming as an advisory from the AHA. I think if the AHA comes and say aspects of 3 or more, people will have a pretty hard time not treating somebody unless there is a certain situation. But that's our current guideline, and we'll see what the AHA says. And the ESO also will have their guidelines very soon.
Right. What about the infarct core size? You show the same aspects for 4, and there's huge difference.
Right.
See what is your infarct size? So-called threshold.
We just stratified that patients with 150 or more are not ideal candidates, so to speak. I mean, you can make arguments both ways. You can make argument that there was no heterogeneity, and that you can make argument that you have limited number of patients to show statistical significance. I think it's quite reasonable to have a discussion around those patients. I think it's quite reasonable also to take the other factors into consideration, the age and the time and those.
Right. So I think age is another significant factor we often should consider. Do you have a typical age combination with the modified ranking? I mean the aspect 3 and 150 cutoff.
Yeah, I mean, in the imaging paper that will present at the ISC, we have data on the age, and we have data on the time along with the core volume. What I can tell you is we don't take things as a cut, because it's very hard to do this statistically. But as the age increased, as the core volume increased, as the time from imaging to reperfusion increased, the likelihood of achieving MRS of 0 to 2 and 0 to 3 decreased. So that's, I don't think that anybody can give you more than 75, more than 70, but rather look at everything together. I mean, I think, the cardiologists, do something similar and more advanced than us, that they have models before they do their cabbages and all of that, to put likelihood of achieving certain outcome we may be hitting there, but at the end of the day, everybody gets a cabbage, and everybody probably it gets a TAVR, right? So
Yeah.
you know, I mean, I think we are going towards, everybody eligible gets the opportunity at least for consideration, and some people may not make the cut just because of those factors that we discussed: the age and time and core volume.
Thank you so much. Excellent.
No problem. No problem. Thanks for the good question.
If there's any role for collateral grading in terms of further specifying the patient selection in the studies that you discussed with us today, and is there a subgroup analysis of collaterals?
Yeah, there is. None of the studies used collaterals as an inclusion or exclusion criteria. There is something from Select 2 that will come out. We have 10 presentations at the ISC. Half of them are oral presentations, and that's one of them, the collaterals. I mean, I think those are ancillary, but not hard cut, treat or not treat. Of course, the collaterals can be a reflection for CT perfusion, and CT perfusion can be a reflection for collaterals. Again, I think those are ancillary.
Yeah. I don't see any more questions in the chat. Yes, we'll wrap up right here. Thank you so much for joining a comprehensive update.
Well, thank you for having me. I mean, I will, people need to hear that you actually chased me with several emails and several, so kudos to you, really. Good job. Sorry if I was a bit difficult, but schedules can get busy, but thank you for having me. It was my pleasure. I hope everybody enjoyed it. I hope next time, as Dan said, in person, and I hope everybody have a wonderful weekend.
Thank you.
Thank you.